There is nothing that is non-medical about a hospital. I repeat, there is nothing that is non-medical about a hospital. Every facet, every aspect of a hospital has a bearing on patient safety and physician well-being. For example, as a doctor, did it ever occur to you that flawed capital structure, mix of debt and equity, and we'll discuss this later in the series, that flawed capital structure or a poorly funded working capital design by the promoters or management could affect patient safety? Did it occur to you that poorly designed operating rooms, poorly placed nursing stations could affect patient safety? Maybe, or probably not. Think about this. When there is an adverse event, how many times have you seen patients suing the CFO or the CEO or the board of the hospital? Rarely, right? When there is a sentinel event, aren't you, as the physician or the admitting doctor, summoned to explain? Isn't the likelihood of you getting sued, the doctor's reputation getting tarnished, a lot higher than that of the CEO, the CFO, or probably even the hospital? You see, what we need to remember, and what we always forget, is that when shit happens, as they say, when shit hits the fan, many things go wrong simultaneously. But we are all generally very good at finding one reason and pinning it on one reason. And it's easier to find a scapegoat because we don't want to deal with system complexity. Right? We're just plain lazy to investigate, examine, dig deeper, and get to the truth. As I get older, I think I've become very cynical. And I think that nobody really gives a shit about the truth. Everybody's comfortable in their own opinions, with their own belief systems, and truth is really of secondary importance. People just want to feel comfortable, and whatever belief system and whatever opinion makes them feel that. So we somehow wired not to really get down to that bare naked truth that is behind the behavior or reality that we observe. And this is where Professor James Reason comes into play. Professor James Reason, a professor at the University of Manchester, developed the Swiss cheese model in the 1990s. It is a simple yet fascinating model to illustrate the complexities of error prevention and risk management, especially for complex systems. It was probably originally developed and applied to aviation, but it has since then been extended to, of course, healthcare, but also to cybersecurity, transportation, power plants, manufacturing, etc. So, as the name itself indicates, the idea represents the characteristic Swiss cheese, cheese with all those holes in it, right? And those holes in each cheese layer symbolize the vulnerability or the danger that is lurking in that layer. And each layer represents a defense. So, good training, good policies, good culture, good capital structure, good recruitment policies. These are defense layers. And in these defense layers, there can be holes, there can be vulnerabilities. Right? And when the holes in these different layers align, then a pathway or the likelihood of an adverse event increases. An error or an accident pathway gets created when these holes align. And people, management, leadership, who are responsible for governance must ensure that these gaps and holes are filled And more importantly, ensure that the overlap of these different layers are such that even if there are vulnerabilities that are lurking, one layer ensures that it doesn't pass through. No single layer is foolproof. No single layer is foolproof, and the emphasis must be on multiple overlapping safeguards to prevent adverse outcomes. Because accident causation is systemic. Blame cannot be placed on an individual. And this is very important. You know, when a plane crashes, we investigate the system, the event. When a patient dies, we generally say, who's the doctor? Now that attitude must change. And we should look at the Swiss model, adapted for hospitals, a little bit closely. Let's delve into this next. Okay, let us look at the hospital Swiss cheese model. Right? This is the model developed by Professor James Reason, which has been adapted to a hospital scenario. And the idea is that there are multiple layers of defense, right? And each of these layers might have holes which represent vulnerabilities in that layer. So, for example, funding and resources. So, how the promoter or the management funded the hospital. So, as I said earlier, if there is a hole where working capital was inadequately provided for, or the debt equity did not adequately mirror the business and the financial risk, then it creates a danger. If the technical aspects in terms of design of the hospital, the design of the CSSD, the design of the nursing stations, the placement of the equipments, etc., that can create a vulnerability. If maintenance is not done periodically, if equipments are not periodically calibrated, dangers and harm can lurk in those defense areas. The provider, the hospital management and operations, if they don't provide for adequate training and if they throw a nurse into an important area like an ICU and is not adequately trained, it creates danger. If there are distractions and not adequately provided for in terms of rest, then you're putting a lot of risk then you're injecting a lot of risk into the system because doctors are fatigued, nurses are fatigued, and this is a provider or a management issue, as is the issue of culture. So culture always comes top down. So what kind of culture have you promoted? If it is a culture where nobody cares about people and nobody cares about efficiency, then you're like one of those bureaucratic government agencies where everybody is just happy doing nothing and it gets very political, right? Or if you're a culture which is extremely production driven but not adequately people driven, then also you have a problem. So anyway, the point is significant dangers and risks lurk when you have poor policies and a culture that has not been built around the team, and in a team where, let's say, the handovers are hastily done. And this can create a lot of risk, or responsibilities are shifting. So you can imagine how many different layers which are supposed to act as defenses, but if those layers are not carefully designed, and what is on the slide is just a small aspect to just give you an illustration of how patient harm happens. Patient harm happens when vulnerabilities in each of these and several other layers that are not on this slide align and cause an accident pathway, right? That is when patient harm happens. But what do? We ask a simple question: who's the doctor? And nail the doctor. That attitude must perish, and we must put an end to this by understanding that patient harm is systemic.